thank you all for joining today's Connect and Explore webinar. I'm Elaine Arkin. I'm with the Coordinating Center for NCCOR, that's the National Collaborative on Childhood Obesity Research, and I'll be moderating today's webinar. Today's program will feature a spotlight segment on a new model for integrating clinical community systems and tackling obesity. And after this main feature, we'll have a one-on-one segment where you can ask our presenter questions. Then we'll discuss what's next for NCCOR when it comes to exploring research and practice around what works in linking healthcare and community systems. We'll also mention how NCCOR is celebrating National Childhood Obesity Awareness Month. If you have a question for our speakers during the presentation, please don't hesitate to write it in the chat box on the left of your screen. And if you need technical assistance during today's webinar, please let us know using the same chat box. If you're having trouble logging into the webinar but can hear us on the phone, you can email us at NCCOR, that's NCCOR, at FHI360.org. That's FHI360.org. And we'll work with you to resolve the problem and get you on the webinar. One final really important technical note, especially since there are a lot of people on this webinar. If you have decided to listen to our webinar today using your computer speakers, please turn down or mute your computer microphone. This will greatly reduce the potential for any background noise. So thank you in advance for that care. We'll also be live tweeting during today's webinar, and if you're on Twitter or other social media, we encourage you to join the conversation by using the hashtag ConnectExplore and following the Twitter handle at NCCOR or at NCCOR. Our speaker today is Dr. Bill Dietz. Bill is the director of the Sumner M Redstone Global Center for Prevention and Wellness at George Washington University. The center aims to accelerate the search for solutions to obesity and other public health problems that are on the rise in our country and worldwide. Dr. Dietz is a member of the Institute of Medicine, which provided the impetus for the framework that you'll be hearing about today. Thank you so much, Bill, for joining us. But just before we get to Bill, let's start things off. We'd like to open with a brief poll. To the left of your screen, above your name, you'll notice a button with the letter A in it, like the one shown here. After I show you the poll question, there's just one question, move your cursor over this button to see the drop-down, and then click to select your response. So our poll question is, how familiar are you with today's topic? That is, integrating clinical and community systems to tackle obesity. Please select either A, very familiar, B, somewhat familiar with this topic, or C, not familiar. Again, from the drop down on the left of your screen. Now we'll give you a minute to do this, and then we'll show you the response. And Jordan, just let us know when you're ready.
I think we're ready.
Okay, so what did everyone say? Do we have a summary? There you go. Well, it looks like most people, 48%, are somewhat familiar with the topic. So, Bill, that gives you an idea of where your audience is. Thank you so much to everyone who participated. Now, I'd like to turn it over to Bill for our Spotlight segment. Bill?
Thank you, Elaine, and thanks to NCCOR for this opportunity. As Elaine indicated, today's topic is a new model for integrating clinical and community systems to tackle obesity. And it's important to disclose right at the outset that that several of the authors of this paper were also representatives of the models that you're going to hear. This included people from, a person from Kaiser Permanente, another person from Health Partners Minnesota, and somebody from the YMCA, Lowell Solomon from Kaiser, Nico Pronk from Health Partners, and Matt Longjohn. I also need to disclose that I'm a consultant to the Institute of Medicine, and as Elaine indicated, this project grew out of one of the innovation collaboratives under the Institute of Medicine. The Institute of Medicine organization is the Roundtable on Obesity Solutions. The composition of the Roundtable is that it's composed of about 50 members who represent a variety of groups. These include NGOs, nonprofits, health insurance plans, and industry. And the mission of the Roundtable is shown on this slide. That the intent is to enhance and accelerate discussion and the development and implementation of multi-sector collaborations, and focus on policy, environmental, and behavioral initiatives to increase physical activity, reduce sedentary behavior, and improve the healthfulness of foods and beverages consumed to reduce the prevalence and adverse consequences of obesity and eliminate obesity-related disparities. And we take this quite seriously. We are focused on solutions, not the problem. And the issue then becomes, how do we achieve these goals? Within the Roundtable, there are 4 innovation collaboratives. These are subsets of members of the Roundtable and also include people from outside the Roundtable, and focus on these kind of sub-areas of interest. So there's a collaborative on physical activity in youth, a second collaborative from which this framework emerged, which previously has been known as clinical and community integration for obesity prevention and control, and now is called integrated health. A third on early care and education, and a fourth on the CEO Innovation Collaborative. Now, the challenge for all of us is, how do we achieve the triple aim with respect to chronic disease prevention? And the triple aim emerged from the Institute for Healthcare Improvement and calls for strategies that reduce costs, improve patient experience, and improve population health. And this historically has been somewhat of a linear model of care. For example, many people consider the pathway to improved outcome beginning with screening, diagnosis, assessment, the development and implementation of an intervention which feeds back on the diagnosis and then improves outcomes. This particular pathway was developed for asthma spectrum disorders. But I think we all understand how much more complicated this is, and that we need to move beyond the individual focus to focus more on policy and environmental changes in institutions, communities, and federal and state programs. And as we move out across the socio-ecological model, our reach improves, and even though the effect size of these initiatives may be smaller, the overall effect, because of its reach and impact, is greater. Now, one way that to think about what I'm about to share with you is that this is the third iteration of the chronic care model. This model began with Ed Wagner's model in about 2004, and you can see here that the focus was on changes within the healthcare delivery system. And this is quite appropriate because of the prevalence of chronic disease, and I probably don't need to remind you that 34% of adults and 17% of children and adolescents have obesity. And in order to accommodate those patients, to deal with those patients, we really need to change the way the health system and the healthcare organization is put together. So this involves changes in clinical information systems, support for how clinicians make decisions, changes in the way we deliver care, and self-management support. And the ultimate product is improved outcomes. Now notice community resources and policies were part of the original care model, but the primary focus was on the health system. And about 3 or 4 years after the publication of the chronic care model, we adapted this model for the care of obesity and other chronic disease problems. So you still see the medical system here, but in contrast to the last model, we've put patient in the case of adults and family in the case of children, self-management as central to the model. And we were also compelled to recognize that the changes in the environment were essential to complement what was trying to be accomplished in the medical system. That we couldn't very well improve physical activity unless the environment in communities or work sites or schools was improved and offered opportunities that were safe and utilizable. But still, in 2007, we conceived of these as separate systems, so medical systems and environmental systems. And one of the, when we began the collaborative, which is now known as the Integrated Healthcare Collaborative, we began thinking about the third iteration of this model, which is shown in this slide. And this is I recognize this is a complicated slide, so I want to walk you through it very slowly. So again, you see family and individual empowerment and engagement central to the model. You also see on the left-hand side the need to change the care delivery system, and some of the same elements in the original model, like information systems, decision support, design of the system, self-management support, are still there. But what we've added is the need for clinicians to understand the local patient environment. And clinicians themselves are listed there because of the importance of dealing with their own physical activity and dietary patterns, which in turn affects counseling. And particularly important to enable them to deal directly with the stigmatization of people with obesity that is so widespread and shared by clinicians. On the right-hand side, you see the community systems. These involve resources, services, supportive environment, and social norms. Within all of these systems are embedded in this broader system, which you see at the bottom, of population health. So if you think back about the social ecological model, those outer rings of the social ecological model come into play in terms of their impact on population health. You also see at the top of this framework the need to focus on equity, because we know that unless we deal with the inequities that attend obesity and other chronic diseases, we're not going to make a lot of progress. You also see the need for training and education, and I'll come back to that in a few moments. But the key to this system is in this blue arrow that underpins the whole area, and that's the need for integration. And integration itself presents a major challenge, and the integration depends on the existence of either an integrator or integrators, because more than one group can play this function. The single most important characteristic of an integrator is to serve as a trusted and accountable leader. And Gary Gunderson, who is at Wake Forest in North Carolina, has said repeatedly that change moves at the speed of trust. So that unless that trust exists between clinical and community systems, change is not going to happen. But integrators also, because of their trusted role and because they have correspondence with both sides of this model, also have the capacity to engage partners from multiple sectors and to, particularly important, to focus on how one achieves agreement among the stakeholders for shared goals, and equally important, how one measures progress towards those goals. Part of this integration process is this joint assessment of community resources, including workforce capabilities on both sides, both within community systems and within clinical systems, and the ability to work with partners to adjust accordingly. You see again the focus on systems to make policy and practice changes, and also to an important element is to convey what's working to both sides of this model. Additional functions of the integrator and integrators is to sustain these changes, and part of that depends on the next bullet on this slide, which is the identification and implementation of financial sustainability for this model. And a particularly big challenge here is the strengthening of community resources to augment what is happening clinically. And that means both advocacy on the part of clinical organizations and investments on the part of a variety of funders in strengthening and the capacity and effectiveness of those community organizations. Some of those funding streams can come from the community benefits initiatives of hospitals. Increasingly, the Affordable Care Act is looking at strengthening community investments, recognizing that for many chronic diseases like obesity, that there is no alternative but to work within community systems, just because the prevalence of diseases exceeds what the capacity of clinical systems to deal with those. It's also important to have a mechanism to share data, both at the individual level and the population level. And part of that comes back to how one uses or gains access from the community side to input data into the electronic health records. That's an important barrier. It's also important to have system navigators who help people navigate those both clinical and community systems. And we're beginning to see this nationally with the development and funding for community health workers. And finally, a communication system which enables people on both sides of the model to understand what's working and what's not and where changes need to be made. So coming back to the model, there are a couple of examples of how elements of this system's working. And one of these is the YMCA Diabetes Prevention Program. I think many of you are probably familiar with this program. This is a clinical program delivered in a community setting by providers who are certified in the delivery of this program. And one of the important elements of this program is that they've developed a nice mechanism for communicating the results of their outcomes to providers on a regular basis. The other thing that the Diabetes Prevention Program represents is it's a very nice model for value-based care, because reimbursement for the YMCA does not occur unless the people enrolled in that program meet certain attendance and weight loss goals. HealthyRx is another nice example of how clinical systems are linked to community systems. So HealthyRx was developed at the University of Chicago in a number of poor neighborhoods, where youth were hired to do mapping of the neighborhood and identify resources that respective to obesity related to, let's say, diet and physical activity. Those were then entered into a computer system that enabled providers, when they saw a patient with obesity or, for example, with cardiovascular disease, to link those patients to community resources. So it demonstrates the linkage, not necessarily, though, the investment of the medical plan in those community resources. Kaiser Permanente, for a number of years, has been engaged in healthy eating, active living programs in which they've recognized that investments in the community using community benefits is an important way to address obesity. And most of their investments have been in schools, and they've shown clear results in terms of improved diet and physical activity within schools. And one of the most notable examples of, and what comes closest to this integrated framework, is going on in St. Croix Valley in Minnesota. Health Partners, which is a managed care organization in Minnesota, has partnered with a local foundation to focus on childhood obesity. They've convened over 140 partners. They've got a well-oiled communication system, and they're in it for the long term. And one of the most essential strategies which built trust on the part of the community was that they assured the community that they would be there for 10 years. So it's not, the community perceived this as very positive because it wasn't just a one-off type of engagement. Now, the other thing that characterizes this system is the need to improve training. And at the IOM, we have initiated with this Innovation Collaborative a joint effort with the Bipartisan Policy Center, the American College of Sports Medicine, the Alliance for a Healthier Generation, and the IOM Integrated Health Innovation Collaborative. And what we did in the Innovation Collaborative was to bring together 16 different organizations representing individuals who delivered care for obesity. So these included some of the people that you would, I think, automatically expect, like nutritionists, like nurse practitioners, like psychologists, but also groups like social workers, who we don't generally think of, or kinesiologists, or personal trainers, or groups like physician assistants. And the intent of this effort is to begin to identify common competencies. And what are the kinds of strategies that all individuals need to have in order to treat obesity effectively? And we're beginning to get underway an environmental scan, and ultimately our goal is to develop materials and toolkits that will help foster this. And clearly we're not sure at this point whether one toolkit will suit all or whether that toolkit needs to be adapted for each of these organizations. So what are those potential competencies relevant to obesity prevention and control? Well, this is my list. This has been shared with the group but not adopted by the group. But first and foremost is use of appropriate terms for obesity. This means people first language, and I'll come back to that in a minute, and sensitivity to bias and stigma. Behavior change strategies, which are taught in some of the groups that I mentioned, but are certainly not taught or well used by physicians. A critical piece of integration is not only within clinical and community systems, but within clinical systems alone, there is a need to work with and within teams. Information technology has substantial promise in terms of extending the capacity and reach of providers. But, oops, I've lost the connection here. The need to align clinical services with severity. I don't know whether you can still hear me, but I've lost the connection.
Yes, you're fine.
So maybe I'll have you advance the slides.
I'm happy to do that.
Okay. So if you can go to the next slide.
Okay.
It should be people first language.
Got it.
And this is a critical element, and that I've recently been convinced is a key approach. That the use of the term overweight is descriptive. It embodies everybody with a BMI over 25, but not everybody with a BMI over 25 has obesity. When we use the term obese and talk about obese people, we're talking about an identity, whereas the use of the term obesity is a disease. So we should try to avoid talking about an obese person and talk more about people with obesity. And I think this has political implications. An obese person is more likely to be held responsible for their weight, whereas a person with obesity is more likely to be perceived as a person with a disease. In the next slide, you can see that the language on obesity counseling is also a key element of this, the competencies. So we know that use of the term obesity is not one which is generally acceptable to patients because it's a pejorative term. Terms like weight or unhealthy weight or a healthier weight are much more preferable than the terms in the right-hand column. And when we talk about increasing physical activity, we should try to avoid the term exercise, which denotes a repetitive, boring, and difficult activity. And instead of diet, we should try to talk about eating habits. In the final slide, we come back to the competencies. The ability to work across sectors is clearly not something that most of the providers with obesity are comfortable in doing. but it's a critical piece in order to begin to understand how to work with communities. And it's challenging because of the historic mistrust that exists between communities and clinical services. And finally, in this integrated system, we need to focus on health as well as disease. So this, one of the reasons that this symposium and webinar was moved to 4 o'clock is that these, what I've just shared with you is being published today in Health Affairs, and it was embargoed until 4 p.m. this afternoon. But if you go to Health Affairs, you will be able to find the details around this article, and including the figure, which is not part of the article itself. You have to get into the article to find the link to the figure. But in any case, that concludes my presentation. I would be happy to answer questions.
Thank you so much, Bill. This is just terrific, and how timely. Congratulations that the article is now out. Let's get started with the one-on-one session. Once again, I'm Elaine Arkin with NCCOR's Coordinating Center, and I'm going to help moderate this discussion with Bill. And so if you have a question you would like to ask Bill, please use the chat box on the left of your screen. And we have helpers online with us who are checking for those questions. And let's get started. We do have a first question for you, Bill. This first question you can see on the screen. Some aspects
I don't have access to the screen.
Oh, let me read it to you. Yes.
Oh, thanks.
So, Bill, some aspects of the model you've described have been implemented and demonstrated success. What opportunities exist to begin fully implementing the model, which is a very exciting one?
Well, I think we're as interested in the answer to that question as anybody else, because what we've posed here is a theoretical model and one which we think will enhance care. What we don't have, as I mentioned, is any examples of a completely integrated model. So what we'd like to learn from people on this call and from health insurance plans, and we're in the process of beginning to do this, is how useful is this model, and how are there pieces of this model that people can use, or are there other examples of this model which would help us understand both the opportunities and challenges associated with this model. Ultimately, what we'd like to know is whether implementation of this model improves outcomes and reduces costs and improves population health, whether in fact it meets the triple aim.
So that's really a big challenge, because have you thought about a timeline, Bill? Because you're really changing both how communities work and how the healthcare system works, and which is of course at the local level as well as the policies that you were talking about.
Well, it's hard to fix a timeline on something that we can't control, but we think that this is timely because a lot of movement is towards integrated models. I mentioned the Affordable Care Act, and which I think includes value-based care and a movement towards value-based care. And we believe that investment in community programs that augment clinical programs are ultimately going to be cost savings. One of the challenges there is that when the savings exist on the medical side, how do we assure reinvestment from community interventions? How do we ensure reinvestment and strengthening of those community programs? But this does break down the siloization, and I think that the fact that two of the authors represented very progressive health plans, namely Kaiser Permanente and Health Partners, is promising for the implementation of these programs and integrated systems.
Yeah, you certainly have some great leaders on the healthcare system side to show the way. So there's a question on the screen and another one that's come in that are related. And on the screen, the question is, what changes could healthcare systems and communities begin to implement that would offer the highest impact for reducing childhood obesity. And so let me just add to that, Bill, what has come in a very related question, which is, are there some potential ways for a group that is interested in integration to be getting started? And, are there some learning objectives for people who want to delve into this, whether they are policy types or practitioners or researchers? So we're hearing from the people on the webinar not only what should be done to implement, but how people could get started if they're interested.
Those are huge questions.
Right.
So let me start with the what I think is the easier one, which is how does one think about what to do with respect to childhood obesity? And Steve Gortmaker and I are in the process of putting together a paper that begins to outline strategies for the prioritization of interventions directed at obesity. We knew from our experience at the CDC that multiple strategies began to be implemented by communities when through the CPPW, the Communities Putting Prevention to Work program, and we narrowed the scope of those with the CTG programs. But I think we know enough now to begin to think about how do we really begin to approach this in a more systematic fashion. So we need to begin with thinking about what is the reach of a given program and what is the effect size of that intervention, because that allows us to compare one strategy against another. An additional criterion was published by Claire Wong, who pointed out that the caloric gap necessary to return the mean BMI to where it was in the 1970s. And that is a relatively small caloric gap for 2 to 5-year-olds. It's about 30 calories a day between now and 2020. 150 calories for 6 to 11-year-olds, 180 for 12 to 17-year-olds, 12 to 19-year-olds. So we now can think not only about the effect size and reach, but what's the size of the caloric gap that any given intervention will address. And in the last issue, or maybe it's now 2 issues ago, of the American Journal of Preventive Medicine, Steve and his Choices group published the cost effectiveness of interventions, which is not something that we commonly think of, but again is an additional variable that allows us to distinguish between one intervention and another. Another area which communities and many providers don't even think about is what is the time course of an intervention. And Kevin Hall at the NIH has demonstrated that in an adult, that only half of the weight loss expected from a caloric intervention is achieved in the first year. It takes a full 3 years before the full effect of that intervention is seen. Now, it's faster in children and adolescents, which is why we're seeing, I think, the plateau among 2 to 5-year-olds in the population. And then the final issue is feasibility. So the impact of a sugar drink tax may be substantial, but in many cases, as we see around the country, it hasn't been politically feasible, although its feasibility is certainly increasing. So those are the kinds of thinking that go into how one begins to select an intervention. And all of those can't be defined a priori for communities because every community is different and the politics in the community are different and the availability of resources or strategies within those communities are different. So coming to the second and maybe the third part of the question, how does one really begin to do this? Well, it's important for clinicians to get outside of the clinics and to begin to identify resources and resources and institutions and agencies within their communities with whom they can partner around these issues. So you can't very well expect people to be physically active if they're not opportunities to be physically active, or if they're not parks and recreation facilities that are available and safe. And so one of the first steps that clinicians can take is to begin to engage with those community organizations and to assess within communities what are the resources that are available that would augment what we're trying to accomplish clinically. And then how do you begin to build bridges with those communities? And that involves strategies which clinicians are not generally familiar with. I mean, how does one engage with a community organization is not something that clinicians of all types are generally taught. So it has to be learned. And sometimes, the other question to be asked is, if we're going to move towards an integrated system, who is the integrator? Who is the trusted source? And that's often about relationships. So in addition to what Gary Gunderson said about change moving at the speed of trust, trust moves at the speed of relationships. So beginning to engage with communities from the clinical side is the first step. The second step from the community side is to be open to that engagement, to recognize that and to be sympathetic, if you will, to clinicians and be receptive to what they can potentially bring. That means overcoming a lengthy history of mistrust that exists between clinical and community systems. But it's not going to, that mistrust is not going to break down until we begin to break down those silos. Now, I think I answered all that question, but I'm not sure, Elaine. You'll have to remind me because I still see the connection here.
No, really great. You're right. They're huge questions, and actually, someone has asked specifically about that speed of trust. You were talking about it. You know, it starts more with individuals and relationships, and the change happens at the speed of trust. And so someone said, are there any lessons learned for essentially institutionalizing that trust relationship so that, you know, one of the challenges we all face is that you establish those individual relationships and then someone changes jobs?
Well, yes. So when you think about integrators, there are a number of groups that come to mind. So that, for example, local health departments generally bridge between communities and clinical systems, although they have their own learning curve. Foundations often can provide that bridge, and groups like United Way can provide that bridge. And in each community, there are, those are often groups which or those types of organizations can be used in a variety of communities. But within other communities, there are likely to be other organizations which can provide that integrator function. Churches, for example, might play that role. So integrators need to be identified and sometimes self-identified in order to move that integration function forward.
And so just moving from the integrator to back where what you were mentioning before, Bill, is this requires training because there's a fundamental shift here in how clinicians have worked. And so there's a question on the screen now about that training. What are some of the challenges that a community faces, or this model faces, related to training and making that change?
Well, I think I tried to describe that on the part of the provider side, and I don't in any way underestimate the challenges of diminishing the bias that providers share with the general community about obesity and holding people accountable for their obesity rather than recognizing they have a disease. On the community side, we know from a variety of communities that obesity is seen more as a cosmetic problem, not as a disease risk, and that in many communities that obesity is not connected to diabetes, which people readily recognize. And until we begin to make that connection within communities, there's going to be an aversion to strategies at the public health level to address obesity. So that, for example, unless people understand the linkage between sugar drink consumption and obesity, and the connection between obesity and diabetes, and most people are aware in their communities of the link between diabetes and kidney failure, blindness, and amputations. But unless we make that connection, we're going to have trouble promoting and having communities adapt or adopt strategies like a sugar drink tax, which would be a very effective way to address all three of those problems.
So there's whether it's training or whether it is other ways of getting people to recognize the need for this integration, it sounds like there are challenges on both sides, the community and the policy side as well as clinicians. So that's very helpful. And there's a question that's come in for you, Bill, from the participants on the webinar. What research is needed to contribute to the evidence base regarding healthcare delivery science? It is a broad question.
Yes, that's a very important question. I think, as we all know, science begins with observation. And I think at this stage, what we need are models and field experiments or field studies to begin to dress out this model. I mean, at the moment, as I said, it's a conceptual model. And what we need is more of what Larry Green has talked about so often, which is practice-based evidence to build the evidence-based practice. And that means as the systems move forward, capturing how effective they are in perhaps separate functions is a key element of progress. So that the experience of the examples that I gave, like the diabetes prevention program and its communication strategy, and the example that it represents of value-based care, is a good example where field experience begins to inform the model and build the evidence base.
Thank you, Bill. So another question from the audience. If you were in a hospital system and had access to a large cache of community data provided by the city and county through open data initiatives, such as Chicago is doing now, how would you use that data?
I think that part of the discussion would have to begin with the community, and I'm assuming that Chicago is doing and this hospital system is doing a community health needs assessment. That's something that nonprofit hospitals are mandated to do, and out of that should grow the community priorities, and those could be both augmented and driven by the analyses that those extensive hospital data would provide. And it comes back to agreement in an integrated system as to what the goals are. And once those goals are defined, they need to be measurable in order to assess progress going forward. And that involves a discussion with the community about how those data could be best utilized. And that discussion could well be conducted by an integrator who is trusted on both sides to initiate that discussion and begin to articulate those goals. And I don't think we can pretend that that's an easy conversation because what clinicians may think are priorities may not be priorities that are shared by the community. But that conversation has to start somewhere.
Well, it sounds like that data could be really a useful tool for each sides of this conversation to start to find common ground. So a related question, now that you've brought the integrator back into the conversation, we have time for just one more quick question, and it is, to what extent does that integrator need to be place-based? Could they be, can they model broader integration-oriented approaches beyond a specific geographic locale, where the trust relationship continuum might work differently?
I I don't think there's any reason why that integrator couldn't be place-based if they can meet the criteria associated with the integrator, which we showed in those 2 slides. I think that it's less likely that an integrator will be successful if they are place-based, because they are going to probably need to represent the goals and functions of that place. But there's no reason to say a priori that that wouldn't work if they can meet those integrator functions. And certainly, remember that one integrator may not suit all. There may need to be several integrators, so that some functions might be provided by one and other functions by another. But what's critical in this model is the coordination among those integrators and a shared sense of values, goals, and acceptability of the metrics, and accountability for functioning as an integrator.
That's really helpful. So what you're starting to do, and I bet there's more in the Health Affairs article, is to provide us with some kind of instructional criteria so that when we're looking at how to use to implement the model, there's some guidelines for that.
Yeah.
So I'm hoping that we'll all get a chance when we get off this webinar to go see the Health Affairs article. So thank you so much, Bill. We need to move ahead, but there are still more questions coming in. And so for everyone who is participating in the webinar, please keep posting your questions. We're keeping track of them, and we will post answers to additional questions from all of you to NCCOR's website following the webinar. So, Bill, we're so grateful to have you with us today. This is really exciting. It's sort of a new frontier, but definitely where we all need to be going.
Well, thank you for the opportunity.
Well, and stay with us if you can for a couple of minutes. Let us know if you have questions. So what's next? Well, we know that at NCCOR that there is a lot of interest in this topic, and so it'll be great to talk briefly about what's next among NCCOR members when it comes to exploring research and efforts in this area. There's one exciting activity that might be of interest to some of you on today's call, an upcoming workshop on clinical community engagement models. And there is a work group of NCCOR members exploring emerging areas, and this is an issue that is front and center. In 2014, NCCOR launched the Engaging Healthcare Providers and Systems Work Group, and the work group seeks to gather findings from research on gaps and opportunities that can be translated into and used in clinical and community settings. There is a roundtable being planned, and it's titled Clinical Community Engagement Models, What Works and What Doesn't. It'll be this November. The focus will be to discuss various clinical community models following a format that allows similarities and differences between models to show some comparison between the models, and notes current evaluation efforts and data that are being collected or should be collected to demonstrate how the models are working. So the goal here is to describe community engagement models and programs, illustrating how healthcare and communities can collaborate to address childhood obesity, to describe the program or system level strategies they employ, and if they're amenable to inclusion as a defined community benefit, to describe the degree to which current efforts have undergone evaluation and provide recommendations for optimizing the evidence base and employing evaluation metrics. Now, the meeting will be closed to allow some really intense and deep comparisons between models and explorations, but the findings from this roundtable will be made available on the NCCOR website and shared through a number of NCCOR communication channels. So I hope that you are signed up to get updates from NCCOR. We usually have a pretty quick turnaround to provide these kinds of results, so stay tuned. After you read the Health Affairs article, then know that there will be some more work coming. And finally, as you know, it is National Childhood Obesity Awareness Month. So in recognition of this National Health Observance, NCCOR would like to encourage you to show your support for childhood obesity research by joining our Thunderclap. The goal of this Thunderclap is to raise awareness of the tools and resources available to help researchers do their work. This includes NCCOR projects, which are paving the way for future research. Now, if you are new to Thunderclap, it's a social sharing platform that allows users to sign up ahead of time to take a designated action on a specific day and time. And the idea is that a crowd of people will make a bigger impact by saying the same thing at the same time rather than individually at different times across this month. So once you sign up, which you can see here in blue, then I was just looking at myself, a message will be sent from your Facebook, Twitter, or Tumblr account on September 15, along with everyone else who signs up. So to sign up, you can find the link in the chat box to the left of your screen, or you can visit the NCCOR blog at www.ncor.org/blog. I look forward to seeing you all and seeing lots of noise on September 15th. So it's a pretty cool thing. I hope you'll take a very short couple of minutes to sign up. Now, if you have other questions, either about the Thundercloud or about NCCOR or upcoming activities, please email the NCCOR Coordinating Center. You can reach us at NCCOR, NCCOR, at FHI360.org. That's NCCOR at FHI360.org. Now, we're just about out of time, but I want to note that all Connect and Explore webinars are archived for future viewing. There are a lot of people who joined us for this webinar, and I noticed some were coming in a bit late, and I apologize if there was a backlog and lining up to get into the webinar, but please know that you can access the full webinar and share it, particularly with people who might like to hear what Bill has to say, since it's so timely given the new article that came out just now. Go to NCCOR resources on the website, and then NCCOR webinars from there. And please do share it with your peers. You can also stay connected to NCCOR by following us on Twitter and LinkedIn, visiting the NCCOR blog, signing up for our monthly e-newsletter, and those are all places where you'll hear more about the workshop outcomes that I mentioned earlier. And also visit us at www.ncor.org to engage with the collaborative. And finally, thank you so much again to Bill Dietz for a fascinating presentation, a great new model, and to all of you who have joined us. Before you sign off, just a minute, please take a moment to complete our very brief survey. Your responses will help shape future webinars and maximize the limited time we know you have available to listen in. So I'm going to switch over to the feedback form now. You can write in your input directly on the screen and then hit submit. And have a lovely afternoon, and welcome to September.